my colleague. Great. Um, how am I? I'm enjoying all that's happening. I'm finding that this position that I'm working nationally with the
Yeah.
I know when you were at the chair of the Royal Thai Heme Society, I don't know how you were busy, but I'm getting like literally 2 to 3 emails a day about what's happening in the government in the United States. Like
Yeah.
like whenever it happens on Congress, like how many, how are we going to pay for health care in the future? I'm getting all
Yes.
sorts of notifications. I did get a notification today that the beautiful plan of Dr. Trump, of Mr. Trump for health care, his beautiful plan just passed the House of Representatives by one
Yes.
vote. So it goes to the Senate next.
Yeah.
And we're all going to pay attention to a lot of things that's happening in the United States.
I heard
Mm.
a lot of people were laid off after the new president joined.
There has been I think the NIH and a lot of the health Department of Health and Human Services, um, Medicare, the CMMS, a lot of people, USAID is shut down pretty much. The World Health Organization is losing money from the United States. Oh, it's just in some ways, if you believe in where the United States was for the last 30 years and its role in the country, in the world, and trying to promote healthcare, it's sort of like just a terrible time. That's my
Mm.
opinion as a U.S. citizen. I have other U.S. citizens on the phone that could, say yes or no to that. But
Yes.
So your grant, you have a problem with your granting money, or?
so at the moment we don't, or I haven't. We've the state of Oregon, I have an NIH grant. Dr. Lakowitz has an NIH grant. They've talked about eliminating some of the support, the background support for that. The state of Oregon filed a holding suit. So at the moment, our funds are not yet decided. I have a lot of colleagues across the country um, whose funding has been decimated. Friends of mine in Boston, the Harvard School of Public Health. I think every grant has now been suspended, and it's just yeah. So what's happening in research in the United States is not a good. It's not really admirable right now.
Yeah. Mm.
And I mean,
Anyway,
maybe things always, like, if you look at how President Trump has functioned, it's always, let's make it as bad as it could be, and then we're going to negotiate something back to the middle, so you lose something along the way, but you won't lose everything. But you make it as draconian, look as bad as possible, and so then you won't feel so bad when you get X. Like Medicaid is potentially, they do predict that that's a U.S. supported, government supported, care for the less than elderly, the impoverished. Probably 20% of the U.S. population will come off Medicaid. And one of the things that was on the bill that was just passed today was, if you get health care from the government and you don't have a
Mhm.
job, well, we're going to find a way that you're going to do 80 hours of volunteer service, somehow, and that's how you're going to keep getting your health care. It may
Mm.
not work for sick people so well. Anyway, these are the things that I think about, and this is sort of,
Yeah.
you asked the question. Every day or every week, something in the U.S. is a little bit unsteady.
That's
Everyone needs to move to Thailand because it's a steady government there.
please come,
no,
please
I
come.
don't think so. I
Not
don't
because
think
of
so.
the government, but from other things.
All right.
We
Well,
don't have a stable government either.
well, what I was going to do, you asked me again as part of these training programs that there'd be some where we would have special guests who come in or experts, and to talk on particular, you know, disease. I've been spending my time focused on, as we all know, the CAR T and transplant, but we want to take this collaboration into not just transplant and CAR T therapy, but into the management of heme malignancies. And how are we doing and what we can do potentially over the future, what we can do together. So I want to introduce, so Dr. Curtis Lakowitz is on the call with us right now. And he was, sorry, that just, can you please get it? Yes, that can wait. So Dr. Lakowitz trained his internal medicine at OHSU, but then went to MD Anderson for training and worked in the acute leukemia program. And in that setting at MD Anderson, was very involved in the development of venetoclax and venetoclax-based leukemia induction regimens. He's come back to OHSU to be one of the lead investigators for the development of clinical research in AML. And he's been awarded with a Young Investigator Award nationally. He's got a training award. He's got, but importantly, it isn't just OHSU where he's doing his work. There is an NHLV, there is an NIH function for the development of across the country treatments to improve the outcome of patients with AML. We call it MyeloMatch, and it starts from diagnosis to all the way through refractory disease, where they will be developing clinical trials to cover the entire spectrum of AML. He's been very active now in MyeloMatch, and will be developing trials within that. He has gotten a number of national awards. He's sitting very patiently and listening, but he's a lot to be proud of. He has, quite a large number of publications for someone at his young age, and also publications in high-profile journals. So I've heard him speak 3 times in the past, few months on the update of AML and in the future, in the current update of AML, the spectrum of AML care. And honestly, I've also heard other people speak at ASH, at ISCT, at the Tandem meetings, and he's as good, if not better, than any of the other names. So I really thought that he would be a perfect person to launch this, efforts into malignant hematologic disease for for this set of lecture series that we've organized on a monthly basis. So this is Dr. Curtis Lakowitz. He's on the call. He's still muted, and I don't know if he's hearing me, but I was going to turn it over to him to present to give you his show.
Thanks, Richard. I should
Dr.
I should have you introduce me more often. That's pretty gracious. Let me make sure I have this set up correctly here.
And I'll tell you that the audience here is different faculty members and participant members of the BDMS health system. Dr. Serpo Isser-Grisel, who's in front of you, is a transplanter, did the first transplants in Thailand back, just probably 5 years ago. No, actually more like 30 years ago or more, 40 years ago. He spent time in Seattle in the 1980s, and he's been the chair of the Royal Thai Hematology Society. He's recognized internationally for a lot of his basic research in hematopoiesis, and he actually has done some very tremendous work and has some innovative clinical trials that we hope to do some joint work together with. With that, now I'm set to turn it over to you.
Okay, well, that's wonderful. Hopefully everyone can hear me okay. And thanks again, Richard, for the introduction and allowing me to speak today. So Richard asked me to talk, and he told me to give updates on AML. And so AML is such a broad topic now that I thought I would recycle this talk with a couple new slides in it. This was a talk I gave earlier today, which is the acute leukemia review that we give here locally. And we'll focus on a couple of key points. So here's my conflict of interest. So just a little bit of background. Acute myeloid leukemia, as most of the audience knows, is an aggressive hematologic malignancy with a median age of diagnosis now just updated last year to 69 from 68 years. And this is really important because 61% of the cases of the patients that we treat with AML are going to be over age 65. And let's see, I see a message, allow us to record your talk. Yeah, it's absolutely fine if you record the slides. So, and the reason this is so impactful is because as we have aging populations, we've observed that overall survival in older patients treated with intensive chemotherapy, so our standard 7+3 or anthracycline and cytarabine-based chemotherapy regimens, really remains poor. So this is an analysis that was published now 6 years ago. But when it's broken down into different treatment eras, what we see is that the tail of the curve does come up. So there does appear to be a larger cure fraction. This may be reflective of more patients proceeding with allogeneic stem cell transplant. But by and large, the median overall survival of this patient population still remains less than 1 year. And a lot of this is due to more adverse risk disease biology in older patients, more likely to have complex karyotypes, monosomal karyotypes, TP53 mutations, or have secondary AML from an antecedent hematologic disorder. So the prevailing treatment now for older patients with AML in the United States is the combination of a hypomethylating agent, azacitidine or decitabine, combined with venetoclax. And this is used on label per the FDA labeling in patients that are age 75 or older or have comorbidities that preclude the use of intensive chemotherapy. But I would say, both in our experience here at OHSU as well as across the country, really HMA-VEN combinations have taken hold as the prevailing standard of care treatment for patients down to age 60 or even younger if they have comorbidities. So the first major point that I think is important to disseminate to the hematology community at large is that when we look at the prognostic models we have developed, they are very much treatment specific. So the prevailing treatment model for younger patients that are fit and able to receive intensive chemotherapy is the European Leukemia Net 2022 stratification. And this is data that was actually presented now 3 years ago at ASH by Dan Pollier. And one of the first things that has come to light is that ELN 2022 risk stratification criteria is not prognostic in the post-HMA-VEN era, and that our treatment or our prognostication models are really treatment specific. On the left side of the slide, you can see at this time, ELN 2022 had just been created and updated from the last 5-year iteration of ELN 2017. And really what we see is that while it does appear to separate out favorable risk patients, those patients with intermediate and adverse risk disease really had no improved risk stratification when treated with ELN 2022. And so this tells us that newer prognostication models are needed for this patient population. And this is exactly what has happened over the last 2 years. These are two analyses. The one on the left is actually a validation study published by Alex Batalier at MD Anderson based on the work of Dan Pollier and Hartmut Donner's ASH presentation that I just showed this slide on before. And really what Dan and Hartmut did is they created this 4-gene molecular prognostic risk signature, or we call it the MPRS model. And what this does is this was based on the initial phase 1b and phase 3 study populations from the Vialier study, which was the registration study for azacitidine and venetoclax in AML. And it segregates patients, or I should say stratifies them, is probably a more accurate term, based on the presence or absence of mutations in 4 genes. So if patients have wild type KRAS, NRAS, FLT3-ITD, and TP53, they're considered within this higher benefit group. And you can see here the median overall survival is 29.7 months. And so this is a remarkable change showing how we can individualize and really prognosticate those patients who are going to achieve long-term survival in the context, in the historical context of AML, where median survival for this population was traditionally less than 1 year. Patients, though, were also identified where we still have a lot of room for improvement. So intermediate benefit patients are those that have mutations in KRAS, NRAS, or FLT3-ITD, but with a wild type TP53. And then the lower benefit group, which I would argue is the largest unmet need within the AML community still, is patients that have mutations in TP53, irrespective of all other mutations. And we see the median overall survival in this patient subgroup was only about 5 months. Now, there's room to improve on these risk models. I think the 4-gene MPRS risk score is a really good start. It's a foundational model, and the investigators had the data available to them at their disposal to try to create this. The Mayo Clinic has subsequently published a secondary model in a cohort of about 301 patients that similarly risk stratified patients, but they arrived at this conclusion using different markers. And so this is a risk score where they assign risk points. Failure, this is actually a response-based model. So failure to achieve a CR or CRI was assigned 2 points. Most of us would know, practically speaking, that if you have persistent disease with AML, then that is a poor prognostic indicator. But they also do incorporate the ELN 2022 adverse risk karyotype, the presence of a TP53 mutation, and then something that I think is important is absence of an IDH2 mutation is given a point, because we know that IDH2 mutated malignancies are particularly sensitive to venetoclax-based therapy because they rely more on increased BCL2 expression, which is the target of venetoclax, to prevent activation of the intrinsic apoptotic pathway. And you can see using this risk stratification model that, again, you see stratification of patients into a group that has a median overall survival of about 30 months compared to about 10 months versus 3.1 months in this high risk group. And so this is really just to say that, within the context of this therapy, we have these two prevailing risk models. This is evident in the updated ELN 2024 guidelines that were recently published by Hart McDonough in the fall of 2024 in Blood, and it really reflects these two models. Patients that have mutations in NPM1, IDH2, IDH1 in the context of being treated with Ivoaza and DDX41, but then wild type for those other mutations are considered favorable risk. Those with FLT3 ITD, NRAS, or KRAS mutations but are TP53 wild type are considered intermediate risk, and then mutated TP53 patients are considered adverse risk. So this has really become the prevailing model for how we risk stratify patients with lower intensity therapies. Now, one question that we asked recently is, are all these mutations truly considered equal? I think there's a balance when you're developing a risk model for patients between trying to really individualize prognostic modeling for an individual patient versus what's feasible and what is most applicable to large populations. And a lot of times we have groupings in that setting that may not necessarily be representative of the full underlying prognosis. So this is actually a question that we attempted to answer within a cohort of patients here treated in the United States. And then the NHS group was gracious enough to lend us their cohort of about 450 patients treated with HMA or LDAC-VEN combinations. And one of the things that we recognized right away is that really within this 4-gene classifier risk group, or ELN 2024 classifications, is that the outcomes within the favorable risk group are largely driven by these patients with IDH1 to NPM1 or DDX41 mutations. So patients that are wild type for one of these particularly VEN-sensitive mutations actually have inferior survival that is more somewhere in between the intermediate risk group and the adverse risk group. We also see that oftentimes we like to lump things in medicine. So we like to lump NRAS mutations with KRAS mutations. But one thing that's of interest is that we know that RAS pathway mutations are very prevalent at the time of AML progression on HMA-VEN, but whether or not they're prognostic at the time of diagnosis and how that differs based on the individual gene mutation was something that has yet to be answered. And so we tried to answer this. And what we actually demonstrated is that you can see here on the left, within this intermediate risk group, patients with NRAS mutations tended to actually fare better. They had a trend towards improved survival compared to other intermediate risk group patients that were NRAS wild type, while KRAS mutated patients had particularly inferior overall survival compared to other intermediate risk patients. So this suggests that even within these risk groups, specific mutations carry more prognostic relevance. And this was particularly true in a mutation that was left out of the analysis, which is PTPN11. So there's been several nice publications highlighting the adverse prognostic role of PTPN11. And right now, if a patient had a PTPN11 mutation, but none of these other 4 genetic mutations, they would actually be considered within this favorable risk group. Here you can see that at least in our limited analysis, the 20 patients with PTPN11 mutated disease had survival that was more akin to TP53 mutated AML. And so not only are we able to show differences within the currently assigned risk groups, but we know that adding novel genes into the score may improve prognostication. And in fact, that is what we did with this publication. So on the top figures A and B, you can see these current ELN 2024 risk stratification groups in the United States cohort, which is on the left, and then the NHS cohort, which is on the right. And I think what's clear is that the adverse risk group, the red line, the TP53 mutated patients do poorly in both cases. But what we really see is we see this crossing of the Kaplan-Meier curves with respect to the favorable and intermediate risk group patients. And that's because of some of that genetic diversity that drives the groups. Now, we revised these risk groups, which I'll show you on the next slide here. And what we observed with the revised risk groups is that we actually were able to better stratify long-term survival in patients treated with HMA-VEN combinations, both in the United States cohort, and then this was subsequently validated in the NHS cohort. So what were the changes that we made with our hierarchical classification? Well, we showed in our analysis that patients, particularly with KRAS and PTPN11 mutations, have inferior overall survival. So we considered these adverse risk akin to TP53. Patients with NRAS mutations, even though they had a trend towards more favorable survival in our cohort, but they are enriched at the time of AML progression on venetoclax-based therapies, we had this remain as intermediate risk along with FLT3-ITD. And then one of the biggest changes, though, was that if a patient had a mutation in NPM1, IDH1, IDH2, or DDX41 without these aforementioned mutations, they were assigned favorable risk, but other cytogenetics or mutations that were not classified were considered intermediate risk. And one thing I'm working on now is I'm subsequently trying to validate this yet again in a cohort of about 1,800 patients treated with HMA-VEN. And it really does seem like these favorable risk mutations are the one carrying those favorable risk groups. So then one of the questions I think we need to ask ourselves is, okay, we can identify patients who fare fairly well. You know, I don't think if you were to talk to a patient in the exam room and say, okay, well, you're a favorable risk patient because your time horizon is 24 to 36 months. I think most of us would still say, well, we'd like to live longer than that. You know, can we increase the cure fraction? But tabling those favorable risk patients for a minute, I think what you can really see, particularly if I go back 2 slides, is that, you know, our intermediate and adverse risk patients, even with these revised risk groups, still have a survival of only about a year. And so we really need to figure out how to improve outcomes in these patients. And so this is our current lower intensity treatment approach in patients with AML. So all patients, you know, have a comprehensive physical exam, comorbidity assessment, bone marrow aspiration and biopsy. Most certainly everyone needs cytogenetic analysis, and then really targeted next generation sequencing is key to understand disease biology and perform genomic stratification. We utilize the 2 prognostic models that I just mentioned, either the 4-gene MPRS risk score or the Mayo Clinic risk prognostication model. And that allows us to group patients or subgroup them into molecularly defined groups for a large majority of patients, I would argue. About 7 or 8% of patients will have IDH1 mutations, 10 to 15% will have IDH2 mutations, 30% of patients with AML have FLT3 mutated disease, either TKD or ITD mutated, 30% will have NPM1 mutations or KMT2A rearrangements, about 15 to 20% are RAS mutated, RAS pathway mutated or monocytic, and that leaves about 1/3 to 40% for other subgroups, as there is some overlap between these cases. And this is really important because we now have molecularly targeted therapy or phenotypically targeted therapy for the large majority of these patient subgroups. So one of the second points that is new in 2025, and actually this paper was just published in Blood Cancer Journal a couple of weeks ago, is that there's more data that we really don't need 28 days of VEN in combination with hypomethylating agents. And this is particularly important as we start to integrate these targeted therapies that I just mentioned on that treatment algorithm slide into triplet regimens using an HMA-ven backbone. So this was a retrospective comparison of a shortened venetoclax schedule of 7 days versus a standard ven schedule. This is the so-called 7-and-7 regimen that was first published by the French group. And then this was compared to an MD Anderson cohort. There were some imbalances in the patient characteristics at baseline. There was more active signaling mutations, or I should say, I'm sorry, there's more FLT3-ITD mutations in the French cohort, more N and KRAS mutations in the MD Anderson cohort, and a higher prevalence of patients considered lower benefit in the MD Anderson cohort. And so that may have skewed some of the outcome results here to a degree. But what we observed is that the composite CR rate was 72% in both groups. And so, you can't get a p-value that's, you can't get too much less significant than 0.955, right? But there are some subtle differences between the groups. So the first thing that was noticed is that the cycles to first response, which kind of makes sense, is longer with the 7-and-7 regimen. This is a reduced intensity, attenuated HMA-ven regimen, whereas most patients were going to have their first response, actually all of them did, with the standard HMA-ven doublet using a 28-day venetoclax schedule. The cycles to best response accordingly then was also shorter in patients that received the standard HMA-ven doublet, while those that received the 7-and-7 regimen, there was a higher proportion of patients that needed 2 or more cycles to obtain the best response. But, so this shows us that overall, the efficacy tends to be the same, though it may take an additional cycle or 2 to get there. And what's really important is that overall survival was similar between the cohorts, so no significant difference in overall survival, nor event-free survival. So we don't really seem to be losing disease control with kinetic failure by using a shorter schedule of venetoclax. But I think the biggest question, and I'm actually a little bit agnostic to this, even though I do lean towards, I always use shorter venetoclax schedules because I do think we tend to see less cytopenias with it. But the data from this study actually didn't really demonstrate much difference in transfusion needs or infectious complications, and we'll walk through that now. So one of the reasons we attenuate the regimen is, like I just mentioned, cytopenia management, and then indirectly the risk of infectious complications in the setting of profound neutropenia. So in this study, there was a significant difference in the number of patients that required platelets. So the MD Anderson cohort, which was the full schedule of venetoclax, did require a higher percentage of patients did require more platelets compared to the French cohort. But what you see here is, at least in cycle 1, as well as in cycle 2, the rates of neutropenic fever and then actually transfusion support was similar in cycle 2 and beyond. Now, this is a little tricky. So there may be a trade-off, because if more patients in the 7-and-7 cohort have active disease longer because it takes longer to get their best response, it may be that those cytopenias and the need for transfusions in cycle 1 and cycle 2 are more related to there being persistent disease that's taking longer to clear compared to the MD Anderson cohort. So in practice, the way that I typically administer this regimen is I give venetoclax for 21 days during cycle 1. If the patient achieves a morphologic remission, then I shorten that to 14 or even 7 days in cycle 2 onward. The one exception to that is patients with TP53 mutated disease, because we know this is a strong driver of venetoclax resistance, and these patients can stay cytopenic for a long period of time, is I usually only start with 14 days of venetoclax for TP53 mutated AML, unless the patient is incredibly robust. And, so for instance, right now I have someone in their 50s with biallelic TP53 mutated AML that I'm giving 14 days of venetoclax with 10 days of decitabine for instead of intensive chemotherapy. So kind of just summarizing, new risk prognostication model for venetoclax-based treatment. Shorter venetoclax durations are okay. This is important as we think about using this as a backbone for triplet therapy, which we'll talk about here in a little bit. And also if we use it as standard of care to mitigate cytopenias, so we don't have patients that are neutropenic, as we would say in Nebraska, until the cows come home, meaning neutropenic forever. So what else is new in 2025? Well, one thing that's very exciting is we have a new molecularly targeted therapy. We have our first FDA-approved menin inhibitor with revumenib. So let's talk about menin inhibitors in AML. So menin is a scaffold protein that is encoded by MEN1, and it essentially regulates gene transcription of HOX genes, particularly HOX9A, and then MICE1, through its interaction with KMT2A rearrangements. And what menin inhibitors do, as shown here on the right is with revumenib, is they interrupt this menin KMT2A scaffold, and this epigenetic disruption then silences HOX gene expression in MICE1, or maybe silence is too strong of a word, but downregulates this, which leads to differentiation of the cells and then apoptosis through the wild type mechanism. So this is a very busy space in AML right now. There's actually 4 different named menin inhibitors currently in development. Revumenib is the one that was the first in class inhibitor shown on the far left, and it was the first to be FDA approved, currently approved for the KMT2A rearranged AML subgroup, though there is also data that was just published last week in Blood in the NPM1 mutated relapse refractory AML population. And so we anticipate there may be regulatory approval for that indication later this year. Ziftomenib, bleximenib, and enzomenib are the 3 other menin inhibitors that are working their way through monotherapy, doublet, triplet, and intensive chemotherapy trials. And so I thought we'd talk about some of those here. Enzomenib is the one on the far right that's a little bit of an outlier. At least the company wants us to believe it's an outlier. This one, instead of using a tertiary amine bond, it has an amide bond. And the company believes that this will overcome some of the resistance mechanisms that have been described to revumenib, where patients that are on revumenib develop a MEN1 mutation, which then changes the conformation. And so revumenib is no longer able to fit into the binding pocket. We'll have to see if this bears out in clinical practice. This is the trial schema for the Augment 101 phase 2 study that gained regulatory approval of this agent in the United States. So this was actually a combined pediatric and adult study. Patients over age 30 days were eligible, and it was an all-comers leukemia study that was for patients with specific genetic targets. So it enrolled relapse refractory AML, ALL, or mixed phenotype acute leukemia, as long as they had a KMT2A rearrangement or were NPM1 mutated. They couldn't have active CNS disease. That was the main exclusion criteria. Patients were given Rev 160 milligrams Q12 hours. And these are the 2 cohorts that were included, like I mentioned, but we'll just talk about the KMT2A rearranged cohort here. The primary endpoint of this study was the CR/CRh rate, and then key secondary endpoints were additional response rates, duration of response, and time to response. So this is the study population that was included. Most patients did have AML, high frequency of RAS co-mutations, which can be expected in a relapse refractory population. And actually RAS co-mutations do tend to co-occur with KMT2A rearrangement. So they're enriched in this genomic subgroup. About 20% of patients were primary refractory. The median number of prior lines of therapy was 2. 42% of the population, 41 participants, had greater than or equal to 3 lines of prior therapy. 64% had seen prior venetoclax-based therapy, and about half of them had received prior transplant. And so most of us would say that this is a fairly heavily pretreated patient population. The overall response rates with revumenib were 64%. The CR/CRh rate was around 23%. The composite CR rate, including CRi, was 42.3%. And so for being a single agent monotherapy in this heavily pretreated patient population, this was pretty remarkable to see these response rates, even though overall they do seem a bit modest. Median duration of response, though, is fairly short with this as monotherapy, with only a median duration of response of 6.4 months. Now, the subgroup analysis of CR/CRh rates kind of tells us a little bit about where the subgroups where we think it could be working best versus not working as well are. One thing that I would point out is these are small numbers here overall, though 62% of 62 patients or 64%, like I had previously mentioned, did receive prior venetoclax. So a decent sample size, but we only saw a response rate of 16.1% within this subgroup. So this suggests that, maybe sequencing this after HMA-VEN is not going to give us as much of a response, and maybe we should use them in combination. The safety profile was consistent with other agents that have been utilized in relapse refractory AML. The biggest side effects, let's see if I don't think I have a slide on it. The biggest side effects that are really unique to revumenib are differentiation syndrome. So by disrupting that menin KMT2A axis, it works as a differentiating agent. So just like the IDH inhibitors, enasidenib for IDH2, ivosidenib for IDH1 mutated AML, gilteritinib actually as a FLT3 inhibitor can induce some differentiation. These agents, and then of course the canonical agent is ATRA, right, for the treatment of APL. These agents can induce a differentiation syndrome that can range anywhere from within a day of starting therapy up to 3 months. And so this is something that the provider definitely needs to be aware of. QTC prolongation was also observed. However, grade 3 QTC prolongation was rare, and most patients were able to be managed with dose interruptions and then resumption of therapy. No patients came off because of DS or QT prolongation in this study. So like I mentioned before, Rev was FDA approved in relapsed refractory KMT2A rearranged AML in December of 2024. And we anticipate an approval in relapsed refractory NPM1 mutated disease either this year or next year. Pardon me. So all menin inhibitors, and this is where, I mentioned with the enzametinib having a slightly different binding pocket, they really all have similar composite CR rates across NPM1 and KMT2A rearranged AML. And you can see by the ends that I've included here in this table that we really just need more data before we know which menin inhibitor is really going to win out and is the best and most potent to be used in the frontline setting or in the relapse refractory setting. With NPM1 mutated AML, we do tend to see slightly higher CR/CRi rates than in the KMT2A rearranged populations. But again, with only, most of these these subgroups are less than 20 patients. I think right now it's fair to say that the the composite CR rates, so CR, CRh, CRi, is probably around 25 to 40% for these agents, and that's usually what I quote patients when I use them. So now, because we see efficacy within this, single agent, this heavily pretreated population as single agent, the companies have been very quick to move these into the frontline setting. And so this is the COMET-007 trial, which is combining 7 and 3 with ziftomenib in newly diagnosed AML with either mutated NPM1 or KMT2A rearranged AML. The NPM1 mutated cohort was 23 patients. 23 patients were included in the KMT2A rearranged arm. The composite CR rate is 100% in NPM1 mutated AML, so that's difficult to beat. Though I think from a regulatory standpoint, we're going to need more than a CR rate. I mean, that's what the FDA wants anyway for these frontline studies. But we're really going to need to see survival, since we know that intensive chemotherapy results in CR/CRi rates of anywhere from 75 to 90% in NPM1 mutated AML by itself. But I do think that the KMT2A rearranged population, well, first I should say, you can't beat 100% response rate. And so I think that is impressive in and of itself. The MRD negativity rates are encouraging in the NPM1 mutated subgroup. But I think where I'm a little bit more keen on the encouraging findings of this data is actually in the KMT2A rearranged population, where they observed a composite CR rate of 83%, which, traditionally this is a leukemia that's fairly chemo refractory. 75% of these patients were MRD negative. And so those are really robust response rates. And I'm excited to see if that data holds up as this cohort expands. There's no survival data yet for this cohort, The median follow-up was only 31 weeks for the NPM1 mutated AML patient population and 19 weeks for the KMT2A rearranged patient population. So Gus Issa, who was the first author on the initial REV monotherapy paper, is leading this study out of MD Anderson. It's called the SAVE trial. This combines Aztec 727, which many of us now know as oral decitabine cytasuridine or Inqovi. This is the investigational name, combined with venetoclax and revumenib in relapsed refractory NPM1 or KMT2A rearranged AML. And so I think just kind of like the Cliff Notes version of this, or, to summarize, REV monotherapy is approved for KMT2A rearranged AML, results in about a 30 to 40% CR/CRI rate, but responses are fleeting. The duration of response is only around 6 months, sometimes even shorter than that. So this trial is really trying to understand, well, what if we add an HMA-VEN backbone to the targeted therapy? Is this a safe combination, and is this effective? So this is the most recent update. So far, 33 patients have been enrolled here. We see that there's a fairly even split between KMT2A rearranged and NPM1 mutated AML. When we look at co-mutations, again, we see a high prevalence of FLT3 and RAS mutations. This was an even more heavily pretreated patient population. Median number of prior therapies was 3. About half of them had received prior venetoclax, and 36% had received prior stem cell transplant. And some of these patients had also received prior menin inhibitors. The overall response rate was 82%, and we see the CR/CRh rate here was 48%. 65% were negative by flow cytometry, and within the CR/CRh group, this was 88%. If we look at the subgroups on the right, we see that the CR/CRh group rate was 44% in the KMT2A rearranged population, and 50% in the NPM1 mutated population. There were 5 cases with NUP98 rearranged AML included, where it's kind of unclear right now if NUP98 rearranged AML responds to menin inhibitors or not. But in this limited sample size, they had 100% overall response rate, 60% CR/CRh rate. So the way I interpret this data right now is, I do think that using the combination therapy, there at least seems to be an additive effect that is improving survival with a median follow-up of 9.3 months. So very early follow-up, but the median duration of response had not been reached in this patient population, and the median overall survival was not reached as well, with a 6-month OS of 68%. And we're now seeing Aza-Ven and Rev used in a frontline setting. And so Josh Zeidner was the PI on this study. It was actually just accepted into JCO a couple weeks ago. And this is looking at the triplet regimen in both a KMT2A rearranged and an NPM1 mutated patient population here in the frontline setting. And in the frontline setting, we're really seeing high response rates, composite CR/CRh rates of 96%, overall response rates of 100%. Overall, 30 and 60-day mortality was low. And this study was also presented as early data, so there's not enough follow-up yet to really know how this compares to Aza-Ven. But the 12-month survival estimate was 62.2%. So this is actually, my take on this is maybe slightly lower than what I would expect. We know NPM1 mutated AML is very venetoclax sensitive. There's been some nice analyses showing that patients with NPM1 mutated AML treated with LDAC-Ven, HMA-Ven can actually achieve MRD negative remissions using qPCR for NPM1, and some of them may be able to cease therapy and remain disease-free for over 2 years. So, because this is a pooled patient population, it's a little tricky to know in this setting if we're really moving the needle in the NPM1 mutated population. So I think that is going to require a randomized study to show benefit of the triplet over the HMA-Ven doublet. But we have other triplet combinations that continue to show efficacy within genetic subgroups of AML. And so this was a study that I actually helped run, and we published in Blood Cancer Discovery when I was a fellow, of the IDH1 inhibitor ivosidenib combined with aza-ven in IDH1 mutated AML. We know that IDH1 mutated AML fares worse than IDH2 mutated AML. And if we focus our attention to the middle bar plot here, with this triplet in the newly diagnosed AML population, overall response rate was 97%, with 94% attaining a CRC. And within this group that attained the CRC, 77% were MRD negative by flow. And so this is a pretty impressive result. 3-year overall survival in the newly diagnosed AML population was 71%. So the question now is, does adding venetoclax to ivo-aza, because we have the results of the Agile study, which I apologize, I don't have a slide here, that shows a median overall survival of ivo with aza of around 30 months. So does the addition of venetoclax augment that even further? Or conversely, does the addition of ivo to aza-ven improve survival? I think the answer there is probably yes. Venetoclax with azacitidine in the IDH1 mutated subgroup has a median overall survival that ranges from 10 to 15 months. So this is markedly improved compared to that. But we don't know if it's improving survival compared to ivo-aza. That is something that will be tested in 2 studies. One is the MyeloMatch study that I am co-chairing with the Alliance group in IDH1 mutated AML in older adults. And then the Hovan Sack group in Europe is running a study of ivo-aza versus this triplet of ivo-ven-aza. Another triplet that's showing a lot of promise, and we have open here at OHSU, and I've been happy with the results, is incorporating the FLT3 inhibitor gilteritinib with aza-ven. So this is the data published by Nick Short and JCO last year now, where in the frontline cohort of 30 patients, the modified CRC, so this is mirroring the Admiral trial, which had this modified CRC, which included CR, CRI, and MLFS, was 100%. But really, most of these were true CR, CRIs, 96% CR, CRI rate. And importantly, kind of similar to what we're seeing with the menin inhibitors incorporated with HMA-ven, the IDH inhibitors with HMA-ven, FLT3 ITD negativity was observed in 65% of patients by the 4th cycle of therapy. And at the time of data analysis, the median relapse-free and overall survival had not been reached, with an estimated 18-month overall survival of 72%. So again, encouraging compared to historical outcomes. If you remember back at the beginning of the talk where I talked about those 3 MPRS risk groups, patients with FLT3 mutations would be intermediate risk, would have a median overall survival of about 10 to 12 months. So this does look like it's augmenting response and survival. So this is the same slide that I showed earlier, and it's really just to highlight that tailoring therapy for most patients is really becoming a reality now. Access to the drugs will be an issue, and is probably an issue across the globe. It is definitely an issue still here for us in the States when we want to use some of these combos off-label, but I think the future is bright for these lower intensity therapies in AML. There's lots of studies ongoing looking at these triplets with IDH1, IDH2, FLT3, menin inhibitors, and then there's some additional ones that I, because of time, I won't talk about today. One thing that we've taken an interest in is targeting RAS mutated AML or monocytic AML. So monocytic AML has been proposed as a phenotypic resistance mechanism to HMA-ven based combinations. And there's a complex interplay between RAS, RTK pathway mutations in monocytic AML, such that there's kind of 2 prevailing thoughts in the field. One is that the genotype drives the phenotype, and it's the genotype that drives resistance, but it appears to be a little bit more complicated than just genotype or phenotype. And there's like I mentioned, there's quite a bit of overlap. So one interesting approach is using cladribine. So cladribine actually preferentially eliminates monocytic cells. This is a cross-section of these are residual live and grafted cells from a mirroring model of a PDX, patient-derived xenograft, of a patient with both monocytic and primitive AML populations, and then healthy myeloid cells. And what you see is when they're treated with aza-ven, really it targets this primitive population, but there's this large prevailing monocytic clone. When you treat this patient cells with cladribine, we see elimination of the monocytic compartment, but persistence of the primitive compartment. And then when you treat them with aza-ven and cladribine, we see elimination of both. There is this regimen that was developed at MD Anderson known as cladribine, low-dose cytarabine, venetoclax. And when you look at clad, LDAC-ven, and intensive ARC-based regimens, we see that the response rates, so these bar plots on the right are the CR/CRI rates by different treatments. We see that the CR/CRI rates are higher, 83% for clad LDAC-ven compared to 45% for HMA-ven within these RAS mutated subgroups. And so this actually led to a study that we have here. We've enrolled 4 patients so far that's evaluating this regimen specifically in RAS mutated or active signaling pathway mutated AML or monocytic AML. Just as kind of like a prelude to the last topic I'll touch on here is, one of these questions that I mentioned comes up a lot as well, is it the genotype or the phenotype driving resistance in AML? So we do see that there's expansion of this monocytic phenotype at relapse in patients treated with aza-ven. So this is a site-seq analysis done by Shan Pei at the University of Colorado. And this is a patient that had both a monocytic clone at diagnosis as well as a primitive clone. And at the time of relapse, we see this prevailing monocytic clone with an NRAS mutation though. And then the second case here on this fish plot is a patient that had these really small monocytic subclones, but they were also associated with RAS mutations at low VAFs. And at the time of disease relapse, these KRAS mutations grew out. Dan Bottomley, Jeff Tyner, and the group here at OHSU did a really nice analysis using the BEAT-AML database, where they overlaid RNA sequencing defined cell differentiation states. So these were, hematopoietic stem cell-like, progenitor-like, granulocyte monocyte, progenitor-like, pro-mono monocyte, and CDC-like. And then when they overlaid mutations that were statistically enriched within these categories, we do see that the monocyte-like AML is enriched for NRAS and KRAS mutations. So this led us to the question where, so we've seen a lot of published analyses to date on signaling mutations, and then there's also been several papers published that show monocytic differentiation is associated with inferior survival. To my knowledge, there's no study to date that has overlaid the genetics, including RAS mutations that we know are driving venetoclax sensitivity and resistance with AML phenotype. So this is a study that actually was published yesterday in Blood Cancer Discovery that we led, where we looked at the impact of monocytic differentiation in 451 patients treated with HMA-ven combinations. In a univariate analysis, we can see that the hazard ratio is 1.36. Monocytic differentiation, shown here in red, is associated with decreased overall survival. But I think what was most important about this analysis from a clinical perspective is that when we actually looked at patients with these RAS pathway mutations, NRAS, KRAS, PTPN11 specifically, we see that the non-monocytic patients have a median overall survival of about what we would expect from the MPRS risk score of about 10 months. But that when you add in a monocytic phenotype, that survival is actually even worse, and it was statistically significant with a median survival here of only around 4.5 months. So then we overlaid additional mutations and incorporated really important clinical variables that sometimes are actually not included in some of these more scientific papers, such as allogeneic stem cell transplant, included here as a time-dependent covariate. And what we observed is that monocytic AML, particularly in patients that are NPM1 wild type, had an increased risk of death that was similar to TP53 mutated AML or FLT3 ITD mutated AML. And so there does appear to be an independent clinical impact of monocytic differentiation. And this makes sense in the context of venetoclax-based therapy, because we know monocytic AML is associated with altered BCL2 family gene expression, including genes that make up the so-called mediators of apoptosis score. So this is a score where you take the BCL2 ratio, so the ratio of BCL2, which is the venetoclax target, and divide it by other anti-apoptotic proteins that drive venetoclax resistance, MCL1, BCLXL. And what we see is that these ratios, lower means that they're more ven resistant, are lower in monocytic AML for both BCL2 to BCL2A1, which is a different ratio we were investigating, as well as the MAC score. And it doesn't really matter how you define monocytic. That's one question that comes up a lot. Here we defined it using multi-parameter flow cytometry, but also more elegantly using RNA sequencing. And in both cases, they had the lower ratio. So then one question that comes up is, well, can you look at this ratio, this MAC score, which has previously been correlated with event-free survival by a German group, and could this correlate with survival? And so this is some work that's unpublished. We had this accepted at EHA for a poster this year, where we overlaid the mediators of apoptosis score, and it does appear predictive of overall survival itself following HMA-VEN therapy. And what was interesting is that this actually was irrespective of genetic subgrouping. So patients with TP53 mutated AML that had a high MAC score had median overall survival over a year compared to patients with a low MAC score. And then when we look at RAS mutated AML that was in remission, those patients with a high score had a median overall survival that hadn't actually quite been reached compared to those that had a low MAC score. And so I think I'm almost out of time. This is the final slide I want to leave everyone with today. And by no means is this endorsed by the AML community at large and in full, but I think this is kind of how I think about AML treatment in 2025. In the intensive chemotherapy eligible population, we have targeted inhibitors such as FLT3 inhibitors that we incorporate, anti-CD33 antibodies, gemtuzumab for those patients with core binding factor mutated AML. For NPM1 mutated AML, there's really great data out of the UK NCRI trials for using FLAG-IDA with gemtuzumab, but revumenib is following suit closely down the road. I incorporate a lot of venetoclax with intensive chemotherapy in the frontline setting. This is based off some work that I didn't present today, but we commonly incorporated this at MD Anderson, and you can do it safely in the right setting. And then for KMT2A rearranged mutated or KMT2A rearranged AML, we have menin inhibitors. And then really, like I said earlier, the black box is TP53 mutated AML, where I really endorse a lower intensity therapy approach for most patients, unless you get that rare patient that's young, has a very subclonal TP53 mutation, and you think you can effectively eliminate with intensive chemotherapy and take them to transplant. And then I think to spare everyone from all my coughing, I'll go ahead and skip the right side of this, but this is essentially what we just talked about, right? So these intensive chemotherapy ineligible patients have a lot of targeted therapy options now that are being tested in triplet combinations. And so I think there's a lot of options here. And then because Richard asked me to speak, of course, I can't forget, allo transplant is still the only curative therapy that we have to date for our AML patients. And so I actually think these lower intensity triplets are great because they're opening up the possibility of disease control and potential rehabilitation of patients who maybe weren't fit enough for transplant to get into better shape pre-transplant. So in conclusion, hopefully I've shown you that the treatment landscape of AML is quickly evolving compared to historical changes in the field. Prognostication is highly treatment specific. Patients treated with HMA-VEN really need to have their own risk models developed, and that is becoming a realization. HMA-VEN-based treatment is a step forward, but let us not sit on our laurels here. There's a lot of work that needs to be done because most of these patients are still relapsing and dying of their disease. Triplet regimens incorporating molecularly targeted therapies are looking promising in early clinical trials, but we need randomized data to confirm this. And then lastly, menin inhibitors represent a new first-in-class agent approved by the FDA for relapsed refractory KMT2A rearranged AML. And I'm excited to see how these frontline and combination relapsed refractory studies turn out. So with that, I'll stop, and thanks for your time, and I'm happy to answer questions.
Thank you, Dr. Curtis. Dr. Surapon, any question from you? Ajahn Surapon, can you hear me? Any question from you?
I cannot.
I hear you now ค่ะ
Hello.
Hi there.
Hello. You hear me?
Yeah, we can hear you.
Okay, I am very interested in what you have talked. So I think this is the new approach of AML. So I would like to know, after you get the complete remission in AML, how after that the best way is to do allogeneic stem cell transplant. How about indoors without who cannot undergo a stem cell transplant? Can we use for example, venetoclax maintenance?
Yeah, so I'll let Richard maybe answer the question about, lower, like, reduced intensity conditioning transplants for those that maybe are borderline eligible. As far as maintenance therapy, so one thing that I think is not often shared as or disclosed as transparently as it should be is that, especially for a lot of these triplet regimens, they are used as triplets, but only for a period of time. Most patients can't tolerate a 3-drug regimen indefinitely, just like most patients can't tolerate venetoclax indefinitely. And so I'm pretty aggressive. Like, if you're just using an HMA venetoclax backbone, I'm pretty aggressive at whittling back or attenuating the duration of venetoclax once the patient's in remission. And so, the regimen is built to be indefinite, lifelong. So I have some patients that are 2 years out that are receiving 3 days of azacitidine, 7 days of venetoclax every 6 weeks or something like that. And that seems to be okay as long as you're monitoring their disease with a bone marrow every 3 to 4 months. And then, particularly for those patients that have mutations that you can track, right? Like NPM1, FLT3-ITD, if you have those patients, then we send those for MRD testing too. And that helps us feel reassured that by reducing the intensity of therapy, we're not losing efficacy and control of the disease while trying to mitigate that toxicity.
Mm-hmm. We have seen. I have seen.
Yeah, go ahead.
I have seen 2 or 3 patients who getting the venetoclax maintenance every 6 weeks, 6 to 8 weeks, and the longest one is now almost 3 years with the still complete remission without evidence of the leukemia.
Yeah.
So I think it can be one of the practice in those who cannot undergo allogeneic stem cell transplant after complete remission.
Yeah, and those patients are really tricky in the sense that the question that comes up a lot is, well, can I stop therapy? And the data we have right now is retrospective and limited, but it's pretty compelling. If the patient is over 2 years out and you don't detect any mutations, is there any role for continuing therapy? And I think right now I do continue therapy because we just don't know. We don't have that trial done. And it hasn't been run, but it would be nice to see.
Yeah.
And then, for patients that do have targeted mutations, IDH1, IDH2, FLT3, potentially NPM1, I think that is where there's a role that potentially these patients that are long-term responders and in remission, we could actually cease the venetoclax doublet therapy and start them on molecularly targeted maintenance therapy to still obtain disease control. I mean, I do that occasionally with patients with IDH1 and IDH2 mutations, and they absolutely love it because then instead of coming in to get their blood work checked, get their azacitidine, be on venetoclax, they take enasidenib or ivosidenib daily. They come in once a month just for their CBC before each cycle, and it tends to maintain pretty good disease control.
Yeah, I would say that Lou Silverman, who developed single agent azacitidine, has always been a big proponent is you cannot stop or it will come back. The combination's a different story. And I do have a patient who's 8 years out, was sent to me for transplant for high-grade myelodysplasia to AML. Didn't want to go to transplant. And he is 8 years now in monthly azacitidine. It continues in complete remission. Well,
yeah,
I want to
that's a
say
good point. You mean you can also do that. I mean, so sometimes we just stop the venetoclax because that tends to
Yeah.
drive more of the cytopenias than the AZA. Yeah.
yeah. So one, I want to say thank you, Curtis, for taking the time. If anything, I think this is a convincing lecture that the world of AML has changed. Honestly, that is what the message here is. I threw some questions in there, but they could just be pondered. But I'm sure that one, thank you, and I'm assuming, and I'm sure that the team here from BDMS enjoyed this, and your talk will be disseminated at other hospitals for, their CME purposes. So, I mean, it is a new world, and it's changing, as you said, so quickly. It's an exciting time to be in AML.
Thank you. Thank you
Thanks for
very much.
inviting
Yes.
me. It's a pleasure to talk.
Yes, by this week, we will upload for CME learning credit. So all the doctor in related field will 57 hospital will learn from you, Curtis.
Oh, that's great. Yeah. Well, I'm happy to share.
Thank you.
Okay.
Have a nice
Take care,
day to go
everybody.
then.
Thank
Yes.
you.
All right,
Thank
everybody,
you.
take care. Thank you.
Bye.
I'll talk to you all next month, and thank you, Dr. Lakowitz.
Thank you. Bye.
Bye-bye.
Thank you too. Bye.
Bye-bye.